Well, I'm delighted to be here in London for our third Vascular News live broadcast. With me in the studio is Professor Ian Loftus from St George's in London, the Vascular News editor for Europe. Across the channel in Chicago is Ross Milner, the Vascular News editor for North America. And we're joined by a panel of superstars in Professor Dittmar Böckler in Heidelberg, Professor Tilo Kölbel in Hamburg, and also from what looks like a manor house somewhere in Hertfordshire, Colin Bicknell from Imperial. And I'm going to turn to you, Colin, because we had the very, very sad news, didn't we, that Janet Powell, Professor Powell, died very suddenly a couple of weeks ago. And she was a long-term research collaborator with my father, very much for pretty much over 40 years, and most recently worked very closely with you. Would you like to say a few words about the impact that Janet had on research in the vascular area?
So Janet worked closely with your father. She worked closely with countless other people in the UK and around the world, and was a mentor and a researcher with them, and a hero to many. She undoubtedly had one of the greatest CVs in vascular surgery, having produced some of the best known trials in aortic surgery that has shaped the way that we all practice now. And it came as a sudden shock to us that she died a few weekends ago, having worked tirelessly right up to the very last moment. And I hope she was doing what she loved right up until the last moment. We will miss her greatly, and I hope that we all remember her for as long as vascular surgery survives.
Now, I know that she worked to the end, rather like my father. They couldn't stop working and they knew no other way. And in fact, she applied for some funding from my father's legacy research fund to carry on. I think it was the Warrior trial. Is that something that you're now going to take forward?
So the Warriors trial was her last and most ambitious project, to look at over 1,000 women with small aneurysms who were suitable for EVAR, to see whether or not they benefit from a stent much earlier in the progression of the disease, before the disease became unsuitable for endovascular repair. And trying to start that study, she applied to the British Heart Foundation for central funding in the UK. And there are over 10 countries around the world who have also joined, trying to get funding as well. And the Camilla Bottner Fund was vital in funding the early stages of this trial, to get a trial manager in place and to start some of the really necessary basic work for the Warriors trial. And I hope that it will now spring to fruition. We shall try and make it work for Janet.
Do you just want to explain a little bit about what you're trying to show, or what Janet was trying to show?
So women in vascular who undergo vascular surgery, no matter whether they're operating on the carotid or legs or aneurysms, do much worse than men. And if you ask 100 vascular surgeons, usually who are men, they will all tell you they know the answer, but they don't usually know the answer. It's usually a multifactorial reason why they're not doing as well. But one of the reasons in aneurysm repair, Janet's theory was that women are both have smaller aneurysms but they rupture much sooner than men. And also, if you look at the suitability for endovascular repair in women, as they get to 5.5 centimeters, only a third of women are suitable for endovascular repair. So repairing these aneurysms at a smaller size, between 4 and 5.5 centimeters, may well confer a benefit overall in the long-term aneurysm-related mortality and quality of life of these women as they go through. So it was a 5-year follow-up of over 1,000 women in over 10 different countries to see whether there's a benefit from early stenting.
Fantastic, very interesting. Any final comments from anyone about Janet?
Just a tragic, oh, sorry.
Yeah, Ross, sorry.
No, I was to say, just a tragic loss for all of us, someone that was I think, universally revered. And I think all of us, when we were in an audience and knew Janet was there, waited for her to always have probably the most profound comment. So it'll be hard as someone who attends a fair number of meetings to come and not see her presence there, because she definitely was an amazing presence at the meetings and always had just such profound comments.
Yeah, I can just echo this. Janet was a great example for every vascular surgeon. I will find it very difficult to sit at Charing Cross not having Janet beside me. I think you made it very clear, Stephen. You said, what did Janet want to show with her studies? Actually, the difference with Janet was, I always had the feeling she didn't want to show something with her studies. She wanted to study. And the way her studies were designed and set up was really to honestly study a subject, be open for different outcomes, and not biased for anything. In contrast to many others who wants to show certain outcomes, she was open. She was a genuinely academic, research-minded person.
Yeah, well, that's very helpful. Listen, I think it tees us up for the next discussion, which I'm going to turn to you, Ross, because as the Warrior study was all about the threshold for intervention and whether earlier intervention in women is warranted, perhaps you can sort of tell us where we are. We obviously had the UK small aneurysm trial that my father and Janet published together on, and also in the United States, I think there was the Adams study as well. So, are we about to see a reappraisal of when to intervene, Ross?
Yeah, thank you, Stephen. And you're exactly right. This is a perfect segue from what Colin talked about with the Warrior trial. I think it's very interesting. I think for many of us now, when we have discussions regarding thresholds, actually we're talking about potentially larger sizes. I think we look at 5 centimeters for women, 5.5 for men, but as all the balance of risk benefits of interventions, I think there's been more discussion on waiting till aneurysms get a little bit larger. And now we're doing clinical trials to look at smaller aneurysms because it may be less of an operative risk for patients. So I think we're in a very interesting time regarding thresholds, because I think there is not much clarity here and there's a lot to discuss. So, I'll put it out to the group. Should our thresholds be larger? Should they be smaller? I think there's a lot of controversy that's surrounding this right now.
So, Ross, if you ask me, I think patients are on much better medical education, medication, and also educated by social media, by physicians. And so I think, yes, we know more that on one hand, prevalence is decreasing. On the other hand, I think rupture rate was overestimated for a long time. So I adapted in my clinical practice really the new thresholds, which were different in different society and guideline recommendations, by the way, which was not a good thing. Now they're very unique. So I'm very, very defensive, especially with iliac arteries. We had a threshold of 3 in iliac aneurysms, and we go up now to 4. And finally, my comment would be on the threshold discussion is that we are doing aneurysm repair now for 20, 30, 40 years, and we still have the diameter as the own criteria for indication, which makes me a little bit, sad that we don't have other predictors, all those risk calculators. Difficult to predict rupture in an individual, but I think that's where we have to go beside the threshold discussion.
I echo that, Dittmar. I think it was great science at the time, and it helped us enormously in our practice, but I'm not sure it's such good science now when we're so more advanced with the therapies we have. And maybe we need a better algorithm. I mean, size should be one part of a much more complex algorithm. But also, we talk about rupture rates, which I'm certain in the UK now are so much lower than they were. We now have data from our screening program that would suggest rupture rates for a 6 centimeter aneurysm below 1% per year. So, it's maybe not rupture prevention we should be thinking about so much, but actually patient expectation. We think much less about what patients expect and what we want to achieve. And I know Janet was doing a lot of work on this, and it was one of her big issues was that sometimes we should actually ask patients, what do they want? And that should be a big part of our decision making relief of anxiety, ability to drive and travel, ability to get insurance, these sort of things that we sometimes forget. But that should be incorporated into the algorithm when we decide whether to treat or not.
Ian, I think that's an excellent point. And we have a lot of patients that come to us that have been referred from a non-vascular surgeon that get told you have a ticking time bomb.
Yeah.
Sometimes with a 3.5 or 4 centimeter aneurysm. And I think one of our responsibilities is to educate that person to know, look, that risk, you don't have a ticking time bomb. But on the other hand, I think you've brought up good points in terms of strong family history, people that have other risks that are preventing them, whether they live remotely, some concerns about, if they rupture, what would happen. And so that definitely has to participate in it. But I think we struggle a little bit because the patients get this information that's not necessarily accurate from a non-vascular specialist, and then we get stuck dealing with navigating through that challenge.
Yeah. Can I just say, it seems like you've got some data, and clearly the algorithm does need to develop. Time moves on, and sizes and everything, I'm sure. But what about the thoracic aorta? I mean, what is the threshold for intervention? What evidence is there about when you intervene for the thoracic aorta? Is there anything at all?
I think Tilo should comment on this. We've been discussing it in guidelines meetings recently, and it's very complex and controversial. I'm very intrigued, and Gustavo, it's a shame Gustavo's not with us, because he's just published in Circulation on the thoracoabdominal aneurysm repairs with very low mortalities, where we really don't know what rupture risks are, but you can now treat with a 2% mortality. But you look out 5 years and nearly half the patients are no longer with us. So again, you've got to think much more carefully about our patient selection, not just based on size, but on comorbidity, about other factors that will...
So just let me understand that. So there's a 2% operative risk if you do endovascular repair of the thoracoabdominal aneurysm, but your 5-year survival rate is quite low.
It's about 50%. I think that's right, Tilo, isn't it? It was a big series from the US. Ross, you probably know these data as well.
Yeah, that's accurate statement, and it's a great point again.
So
but Ian, to my knowledge, it's not. They don't die from rupture.
Correct.
They most die from other cardiovascular events like stroke and of course myocardial infarction. So we actually don't know. Please correct me, and Tilo, maybe you may comment. We don't know the rupture rate of thoracic aneurysms.
Yeah, but I neither know how important that discussion is about the frailty of the patient, because that is the part in the treatment that should remain in the physician's hands. I think the guideline recommendation should provide recommendations for a healthy patient with a certain diameter or certain condition. Then it's due to the discretion and decision of the physician to decide how much to bump that threshold up for patients that have additional risks. So that a large number of patients are dying is important to know and to take into account, but that's not on a guideline level. That's like on a physician on a phisian patient level, where this should be factored in. I hear all this trend, especially coming from the UK, towards higher thresholds, and we will have a very interesting debate at Charing Cross between Anders Van Heijnen and Christian Behrendt on elevating the threshold for AAA repair. What's interesting, on the other end of the spectrum, if we go to the ascending aorta, the societies are lowering the thresholds in view of the reduced morbidity and mortality of procedures, which we also see in endovascular repair. So they are moving from 5.5 to 5.2 to 5.0, and for certain genetics to 4.7. So it's not easy to find the balance these days.
To back some of that data up, the UK did the ETA study, the effective treatments for thoracic aneurysms, and they're a mixed group of patients, but in actual fact, those patients who weren't given surgery, the rupture rate or the aneurysm related mortality for a 6 centimeter aneurysm was less than 10% for 3 years. Far lower than I think we all quote our patients. And I think we are now in a state where we can really look at individualized approaches for each patient based on the patient preference and the patient longevity, whether they're likely to die of something else. And it gives us confidence to leave some of these patients to 6.5 or 7 centimeters, I think.
Well, Colin, sorry, I think we're just conscious of time. Dittmar, last comment, because otherwise we're going to run out of time.
Just one comment, Colin. I think everybody here will agree that there's one subgroup of patients where we lower the threshold, which is connective tissue disease. Young patients who have a higher rupture rate, and so they need earlier treatment. And there, I think everybody will decrease threshold for indication of repair.
Well,
it's important. One
of the good discussion points at Charing Cross is the focus on evidence and the evidence for intervention. And I know there's going to be a cluster of trials in aortic dissection. And Colin, you're leading one of them. Do you want to just kind of outline what you're up to and where you are? And perhaps we can then focus, I think there's a US and a Scandinavian trial as well.
Absolutely. So for uncomplicated type B aortic dissection patients, the standard of care for many years has been blood pressure control and surveillance, but we know that those patients don't do well over the long term. Most of those patients don't take their blood pressure tablets. Between 30 and 50% of them dilate long term, and when you get to an aneurysmal disease of the whole aorta, we know that the operations are of a huge magnitude. And the patients don't like it. They feel like a number just waiting to get to that 5.5 or 6 centimeter, whatever threshold has been sent to them. And so that's why many started to propose early TEVAR in the subacute phase after uncomplicated type B aortic dissection, when the dissection lamella is still mobile and you get good remodeling of the aorta. So the principle being you treat with TEVAR at an early stage, close the primary entry tear, reline the aorta, and this lets you get good remodeling at 1 year and hopefully translates into late reduced aneurysm mortality and reintervention. And so based on a few trials that were done, perhaps underpowered and leaving us in equipoise, we have started the EARNEST study this month, which aims to randomize 470 patients with uncomplicated type B aortic dissection to early TEVAR, best medical therapy and surveillance against the standard of care, which is best medical therapy and surveillance with a 5-year follow-up, with a primary outcome of aneurysm-related mortality and permanent and severe neurological disease or cardiorespiratory disease. We're doing it in the UK. Hopefully, we've got, with our 3.5-year recruitment and all the measures we've put into trying to get every dissection patient that we possibly can, we can achieve our target to answer that question about whether early TEVAR is beneficial. And like you say, there are similar trials parallel, one in Scandinavia, which is also including Holland, I believe, at the moment, and another Improve AD, which is in the US. So with the 3 trials together, we should finally get an answer to this question.
And yours is underway, so that's great news.
Yeah. Ours is underway. We're waiting just for the last electronic case report form build, and we have patients to randomize straight away.
Fantastic. Any thoughts on these trials? And Ross, what about the States? Are you involved? What's your understanding of where they are with that trial, with the Improve AD?
Yeah, Colin described it well. So Improve AD is here in the US. It's led with Ross Milner and a leadership team for the entirety of the trial. Very similar trial design to what you heard from Colin. And I obviously don't know the specifics as much as Ross would, but it's been a little bit of a challenging trial to enroll. We've been a little bit slower than we were hoping, and I know there's a lot of communication now going out to participating sites, where one of the participating sites to try to make sure we're thinking about the trial, we're thinking about patients that are appropriate to enroll and being aggressive about enrollment. But I think it's been a little bit slower to enroll than for us and the team were hoping.
My memory of this was Christoph Nienaber doing the Instead trial yonks ago, and so clearly that didn't really pass muster in terms of providing the evidence. Why hasn't this been sorted by now? What's going on?
Well, I think Colin's touched on it. I mean, I think that trial was probably underpowered for some of the long-term outcomes that are crucial. And Colin, you've touched on this point of problems late on with the uncomplicated cohort that we really haven't got our head around. And I've wondered for a while about this whole definition of complicated, uncomplicated, the definitions around chronicity and so on. And Ross, I wonder if this is partly why there's a problem with recruitment in the US. Is it lack of equipoise, or is it people forget about the trial, or is it people are just treating anyway? What are the kind of feelings as to why the recruitment's struggling?
Unfortunately, Ian, all of the above, I think. And I think some of it, though, is just the logistics of, getting patients to say yes and then getting them enrolled in the appropriate period of time that they fall within that subacute window with the follow-up and the randomization part of it. So I think it's all of the above. And I think there's a lot of work being done to try to streamline the process so we can get patients enrolled.
Stephen, you mentioned Instead. I think Instead did not enroll acute patients. It was, after the acute, subacute, even chronic phase. So this is why it didn't answer the question. And EDSORB, that was the other one, the other randomized trial. That was totally underpowered. They had a long list of exclusion criteria. I think the beauty of this trials, and Colin, please correct me or underline it. I think Ernest and others, they have a very broad inclusion, criteria list. So many patients can be enrolled. The only question which I would have in this discussion is the enrollment time the right one? Because all three trials you mentioned, Improve AD, Ernest, Sunday, they have different time intervals of enrolling patients. So one do after day 10, after some others after 48 hours. Can you comment? Can we pool those 3 trials together once they're finished?
So we have spent a long time making sure that our outcome measures and our follow-up are aligned so that we would be able to pool our patients together from that point of view. But they all do have their differences, these trials, and you've touched on one of them, which is the enrollment. We opted for day 10 so that we could get a pure group of patients that were uncomplicated, in that they were not stented within the 10 days. They didn't have complications within those 10 days. And they're essentially the group of patients that you would have sent home at 10 days for best medical therapy. I think that if you try and randomize people earlier, surely there are more patients that are available to randomize. You definitely would be able to capture them in hospital a lot easier if you're randomizing them at 48 hours. But you also have a group of patients where you might have complications at 3 or 5 or more days.
Okay, we need to sort of crack on to the next topic, which where we look, all eyes will be earnestly on you, Colin, in a few years' time. Can't resist the pun, and hopefully you'll find a suitable podium. If I can suggest Charing Cross in about 2029 as a brilliant place to unveil the results. But listen, let's look at, we can't have everything answered by randomized trials. They take time, and often we get a lot of insights from large-scale registries. And you've been, obviously, as a recent president of the ESVS, do you want to talk a little bit about the initiatives in Europe when it comes to large-scale registries, Ian? Yes,
thanks, Stephen. I mean, I agree. I think dissection is a classic example where a trial is still essential, but so much of what we do with endovascular therapies doesn't really fit a trial design. And we still debate what is best for our patients, open versus endo versus maybe nothing. And I think the registries are ideally powered and designed sometimes to give us these better data. I'm very impressed by some of the data coming from the US, particularly from the ARC registry, so complex repairs with robust data collection and really quite powerful results coming, which will support use of endovascular technology. I'd really like to get people's perspective on that particular data set. And linked to that, we've got European registries. Colin's involved, as I have been for many years, with our National Vascular Registry in the UK, VascuNet in Europe, and now a venous registry that the ESVS is running, which I think is going to be very powerful to give us these real-world data.
What's that venous registry?
This is venous stenting.
Venous stenting.
So deep venous interventions and venous stenting. You know, something that we have a real lack of proper clinical information on. But I'm really fascinated by some of these data coming from US, and I'd be intrigued to know from you, Ross, how that's impacting on interventions there, but also in Europe, what these sort of data are doing for appetite for European registry data of that sort of level.
Yeah, so Ian, our site is not one of the sites that participates in ARC, not because I have a negative opinion of ARC. It's just a smaller group with sort of a different focus of people than I've been involved with, but it's put out some really amazing data, and I think work that's helped a lot of us make decisions about patients. And like you, I agree. I think it's really robustly done registry work, and I think there's a huge value in that. But again, we're not actively participating in my site, but I've seen a lot of the publications and presentations like you have, and I think it's outstanding work.
I think with ARC, well, just reading the headlines, that in the States you still got the FDA saying that open surgery and hybrid surgery is standard of care, is the gold standard for thoracoabdominal aneurysm repair. And ARC is obviously publishing very great results when it comes to endovascular repair of thoracoabdominal aneurysms. And also, I think there's some insight on spinal cord drainage. And so you get lots of technical insights as well as, you know, the results that you get when you carry out endo repair in expert centres. You know, but it's a pity we don't have Gustavo on the line, who's I think in the operating theatre as we speak. But you know, we're looking forward to hearing more about that at Charing Cross. But anything about ARC that struck you when could you single out any data that hit you as being very interesting?
Sorry, Steve, were you asking me that?
Yeah, just anything.
Yeah, I think one of the points you brought up is the spinal cord ischemia and the paraplegia and the need for spinal drains. I think, you know, that group of investigators has really been able to show pretty clearly, you know, the decrease in the paraplegia rate, and also how they've changed their prophylactic use of spinal cord drainage, which I do think is impacting a lot of our decisions for many of us. And I think that's been really one of the most outstanding parts of this work.
Great.
So that's one of the key things, Stephen, isn't it? I think from these registry data, we can refine our practices much better. You know, we get much better levels of sort of granular patient data on demographics and anatomies and so on. And I think it's a great shame, you know, looking at Tilo and Dittmar, we've had access to bespoke endografts for so many years now, and we haven't collected this sort of level of data, and particularly looking at longer term outcomes. And I think that's a shame, but maybe we still have opportunities to do that, to get really robust data.
Yeah.
There's a development that this ARC data is also grouped together with some European data, the transatlantic cooperation already on some outcomes. And I think especially when we want to learn more granular secondary outcomes like target vessel related outcomes, discriminate between different types of bridging stents and different bridging stents. We're seeing now slowly that with these large numbers of thousands of patients, we're able to come up with some results. And at a time where we put together that data with maybe also European data, we will be able to significantly learn and improve our.
Oh, that's news to me. So there's a transatlantic initiative with ARC then in Europe and the States. That's very interesting. And when will you publish? Are you involved with that, Tilo?
I am involved, and there has been data published already. Oh,
great. Okay, that's interesting. Well, let's shift gears to another topic, which is around the prevalence the increasing prevalence of decreasing prevalence of aneurysmal disease, and also the declining skill sets, if you like, in open surgery. And Dittmar, what's going on there? Are we seeing fewer aneurysms?
Yeah, well, I think it has to do with the less smoking and you know, cigarette abuse. I think that has been already showed early on. And then we have screening. We have a better surveillance. We have better medical best medical therapy. Statins are increasing. Compliance of patients are better. So on one hand, I think we're doing better in the conservative arm. On the other hand, I think the aneurysm maybe even has been, overestimated. Some people treat asymptomatic penetrating aortic ulcers such as aneurysm. So I think we should be very careful of what we treat and when we treat, as we discussed earlier. And I think so in my daily practice, really, aneurysms, even working in a high volume center, are going down a bit. That's my really, I can't prove with numbers so far, but I think that's happening. Even having, surveillance and screening programs. And that makes it very difficult, especially if you want to offer both treatment options, open and endo. And my fear is, and my interest will be to really keep open surgical skills alive, so we can really treat patients in a better way. Today, for example, I'm coming from the OR. In one OR, I did EVAR in an old lady. And the other, I did open surgery for a young physician, a dermatologist who has 20 years to go, and he was fit. Remember EVA 1, we had patients who were fit for both, and that's why I did both treatment options. That's how it should be in my mind.
Interesting. Are you seeing similar reductions?
Oh, yeah, I mean, it's been dramatic. So you mentioned the screening program, Dittmar, and the UK screening program is now in its 16th year in the UK. And that's been a fascinating natural history story, because it was based on mass trial, where the prevalence in men 65 to 75 was over 4%, 4 point something. When the screening program launched in England, it was 1.4% odd. We're now well below 1% pickup of aneurysms, and that's 3 centimetre aortas. So we're now approaching, I think, 0.7. Colin might have more up-to-date data on this, but it's halved in 15 years.
Wow.
And that's reflected in the numbers of surgeries we're doing. The rupture rates has dropped even further, and I think that's a combination of, as you've alluded to, Dittmar, the better medical therapy, the slower aneurysm progression, the lesser smoking rates. But our rupture rates now have declined by 80% in around 15 years in the UK.
Well, that's a good thing.
It's a good thing, but it also poses us a challenge as to how we run our services
and keep the skills,
how we train people, especially to deal with emergencies and ruptures. And conversely, dissection rates are going up in the UK. We've now got good data on year increase in type B dissection, which will help Colin recruit. But again, that poses another challenge of how do we train the next generation? Because we need to train more in dissection than we do in ruptured aneurysms. We see more of them now than we do ruptured inferior aneurysms.
That decreasing number, how many are emergency ruptured aneurysms in your, let's say, for instance?
Well, honestly, when I started 20 years ago, we'd see one a week. I now see less than one a month.
It's very interesting, because I remember growing up with my father, it used to be, that was, they typically rupture at night, don't they?
Yeah, usually, and sometimes 2 at night.
2 at night, yeah, exactly.
Queue them up.
Yeah.
But it's almost unheard of now. It's dramatic, the difference.
Is that the same in Hamburg, Tilo, or is everything? Have you got what's happening?
We don't have those numbers, as we don't have that systematic screening in Germany. Correct me if I'm wrong, Dittmar, but certainly we see less ruptures in our practice, but we should be aware that this is mostly refined to the inferior aorta.
Yeah.
So when it comes to thoracic abdominal disease, the numbers are not that clear. My feeling is we still see more elective cases as an increase in cross-sectional imaging continues to pick up more patients.
Right. And what about in Chicago, the Windy City?
Yeah, it's similar here. Obviously, there's been a decrease. We see a little higher frequency of ruptures than Ian just described. It probably is still 1 or 2 a month here. And I echo his concerns. I think we all struggle with trying to understand at times how to get people appropriately trained with open skill sets. And a rupture is not a great time to learn that. And if you're not comfortable doing that operation, it can be catastrophic for a patient. So it's a fine balance. I think what Dittmar just described, being able to do EVAR in one room and open in another room, that's great, but not every trainee gets the opportunity to get that exposure. And then if your first opportunity to do open is a rupture, it's not a a great way to
Well,
learn
I'm
that.
going to be incredibly ageist about this because I know I'm the oldest, apart from Dittmar and I are similar age. But Dittmar, starting with you is, you're comfortable doing both, obviously, and you've said that. But I go to the next oldest, you've obviously been trained in both. You're comfortable doing both.
Yes,
the same.
Very much so.
So people who are in their kind of mid to late 50s have learned both.
Yeah.
But then let's go to the young whippersnapper down there in Colin Bicknell. You're younger, obviously. Are you comfortable doing both? Or are you mainly endo these days? Just Colin.
I think he may have frozen, actually. I think he doesn't want to answer your question.
He's been insulted. Well, Ross, you are a bit younger than me, but not that much younger. You're comfortable doing both, presumably?
Yeah, so, this is, it's an interesting dynamic. Yes, I'm comfortable doing both. But, it's interesting. I have one of my younger partners who was trained by us, who's actually more comfortable doing open aortic work than endovascular work, which I think is not typically the norm. But, you raise a good point. I mean, I think this is a generational challenge for us, but it's also incumbent on us, all professors here, to make sure that we educate everybody to do the best procedures they can do.
It sounds like Stephen, a real challenge. Yeah,
Stephen, the problem is, I think, is that EVA is so forgiving. You can put an EVA in, and you end up with a type 1A, and you can discharge a patient. And type A annually in open surgery will not leave the operating room. So there's a selection bias as well. And I think we need to centralize. I think we need to centralize aortic therapy in some kind, and then bring people into those centers to get trained for 1 year. It's an organization question, but I think not every little hospital should do 5 cases a year. That's absolutely nonsense.
That's interesting about how you then configure services as well as provide the training. I think we've got Colin back. You've moved. You've quivered. Did you get the question I posed to you, Colin, just a minute or two ago? You're as the youngest on the panel. Are you able to comfortable doing both? And how do you keep training in St Mary's so that everyone after you is comfortable doing both?
So we're very lucky at St Mary's in that we've had a long history in the training in the open aneurysms, and it was something that I did an awful lot of my training. But I see the numbers going down. I also see a lot more referrals for opens than we used to. We used to have lots of referrals for complex endo, and now everyone else is better at endo and they're referring more open repairs to us. So I think there are centres where training is possible and that you can learn to do open repair. But clearly there are too many centres if everyone's doing 1 open repair a month, and we really need to get to grips with it. And we probably need to get to grips with how we train open surgery before it becomes a crisis, and that's very difficult.
That's very fascinating. Or maybe we need to, some topic we need to focus on in vascular news and also in future meetings. But I'm just conscious that we're now coming towards the end of the program. But the last topic is around stroke prevalence and how we reduce the risk of stroke. And Tilo, this has been something that you've focused on, both in terms of bringing in new technology, but also carrying out research. Do you want to just sort of give us your thoughts on how we minimise stroke risk when you carry out particularly complex endovascular procedures?
Yeah, thanks, Stephen, for raising that question. We will hear much more about it at Charing Cross in April in London. We have a whole almost a whole session on stroke, and there's no outcome data that will be presented from Imperial, I believe, Colin. As Rick Gibbs is going to show some preliminary data on his carbon dioxide flushing study, as I believe. Stephen, I believe that we as physicians and operators, we have a tendency to fool ourselves regarding outcomes. And the difficult thing is the companies support this because in all these pre-market studies that we see of TIVA devices, but that's not confined to TIVA, also TAVR and TMVR is the same. Everybody likes to report extremely low stroke rates. And when it comes to real world and post-market registry, suddenly we see what the reality is. And the reality remains unchanged. We have a stroke rate in standard TIVA of 4 to 5%, and when it comes to arch TIVA of 10 to 20%. Wow. That's just the reality. And we find that difficult to accept because we find it difficult to convince our patients to undergo such treatment with these complication rates. So it is, we really need to do everything we can. And I'm very happy to see that small steps are being made. For instance, recently, carbon dioxide flushing is used in more centers and has been included in some IFUs of thoracic endografts. But we need to continue with that effort. There's more to be done. And the first thing is that we should look closer and study more carefully and less biased. And probably do some more studies that really look at cerebral damage in terms of cognitive function testing and MR lesions, such as this Imperial study has shown.
So, Tilo, just putting you on the spot, do you know, I guess that there must be some registries that you could provide as a baseline. How does your centre compare, where you've taken all kinds of steps, bringing in new technology, to get rid of the air embolism and the risk of stroke from that? And how do your results compare to those that potentially don't use these techniques like carbon dioxide flushing?
To be honest, I don't know, Stephen, because I don't have a center or a patient population that I think is comparable to what we do. Of course, I can count our strokes and other outcomes, but we really need.
But you can't make it a like for like, essentially, is what you're saying.
I believe we treat patients with worse anatomy than are treated in other centers.
Okay.
And I'm trying to be honest. So I tell you, we still have in Arch TIVA, we have a 10% stroke rate in native ascending landing, and we have about a 5% stroke rate in ascending in replaced ascending aorta. So it's still significant, and
okay,
we need to work on that.
Okay. Any thoughts on this issue, on how we reduce?
Is there a difference between dissection and aneurysm patients regarding stroke in the arch?
Yeah, we know so little, and everybody here probably would expect a higher stroke rate in aneurysm patients, as we believe there's more plaque, there's more thrombus, there's more difficult anatomy to navigate. But surprisingly, if you look at TIVAR studies, they don't show that. They even studies showing a lower stroke rate in aneurysm compared to dissection, which is counterintuitive. So I suspect that we have not understood the mechanism of stroke well enough.
Well, listen, I just want to thank everybody. I'm going to draw this to a close, if you like, as we reach the top of the hour. This has been a transatlantic, pan-European, we've even got a stately home in the background, thanks to Colin's stepping in for Gustavo. But I do want to say that it's been fascinating to hear about where we're pushing the boundaries, where you are all pushing the boundaries in your search for educating the next generation, the skills they need, both in open repair and endovascular, where innovation is kicking in, hopefully to provide better patient outcomes. But lastly, also collecting the evidence, as you, Colin, are with your trial, the Earnest trial and other trials, so that we actually collect the data and the use of registries to provide much needed data. So I think we should mention that Gustavo Oderich, who was going to join this call, but is in the operating room in Houston, where he is in the DeBakey department in Baylor. So he will be giving the inaugural Roger M. Greenhalgh Memorial Lecture that is focused on the aorta, focused on aortic education, as well as evidence and innovation and evidence. So that's going to be taking place at Charing Cross at the end of April. It's been a fascinating discussion. Hopefully the audience has appreciated. But thank you so much for joining us today. See you all soon, and certainly see you all at the end of April in London.